You shouldn't be allowed to practice as a pediatric inflammatory bowel disease doc in the country unless you are part of this network. It is now what it takes to get people to 80 to 80+% remission. The standard of care is so much better if you're part of Improved Care Now that it makes no sense for us to tolerate a practice environment that is not part of one of these networks.
I'm Peter Margolis. I'm a general pediatrician. I'm an epidemiologist, and I work at Cincinnati Children's as co-director of what's called the Anderson Center for Health Systems Excellence.
So I'm Michael Seid. I'm a psychologist by training, and I look at what does it take to make the healthcare system work well for kids and families with chronic conditions.
I'm Kedar. I'm an internist by background. I'm the president and chief executive of the Institute for Healthcare Improvement and faculty at Weill Cornell Medical College.
I want to talk about improving care and what that actually means, because a lot of times when you just hear about improving care, you just think about drugs. Is that the only way, Michael?
Well, drugs are very important. Treatments are important, but they don't work if they don't go into people's bodies. And so there's often a big gap between what we know to do and what actually happens. It's not only the new treatments, right? But how do we make sure that the right people are getting the right treatments at the right time, every time?
When you're outside of medicine, you think that every hospital, every doctor practices the exact same things. Is that right? Or can they be improved?
As physicians, we all come to believe that we are doing our best, but it turns out that when we actually examine our practice, our actual practice, sometimes people slip through the cracks, and sometimes our ability to actually deliver on what we want to do isn't where we want it to be. That's not a matter of largely trying hard enough to do it. It's often determined by the systems that we work in, the way the practice is organized, the hospitals that we work in, the ways in which we structure our practice can really have a big determinant on how effective we are as physicians.
Kedar, how do we create a system that will improve care for everybody?
That's a big question. And I think there's, and what has been traditionally thought of as a black box is the systems that support us as individuals to care for our patients in our communities. What we've learned over decades now is that there's a vocabulary for how to make systems behave differently. That systems are not accidents. They don't happen to us because of external forces, that the people inside of the system architect the system, and we create and perpetuate certain ways of acting and behaving. And that if we want to remake the system to behave differently, then we can do that. There is a vocabulary, a systematic group of tools that we can apply to ways that people are organized, and they can produce different outcomes should we so desire and take deliberate action to do that. We learned a lot of these techniques from manufacturing and from industry, brought them to healthcare, have been applying them in healthcare now for decades. And when we do that systematically and in a disciplined manner, we can change the operating conditions that lead to the better outcomes that we all desire.
Well, what does better outcomes mean?
Well, I think that means, it depends on who you are and what matters to you. So better outcomes to me means something perhaps that's different than what better outcomes means to Michael or to Peter or to you, Jesse. So to me, better outcomes means whether or not we produce health as defined by the individual, as defined by the patient, by the person.
So you guys have built a system around improving care for children with pediatric Crohn's disease. How did you guys even start to think about a network, right? Like how did you, and what were the first steps to improving the care of children, these kids?
There's a long history of collaboration among all of us on the phone going back 20 years. And a lot of the focus was on not just improving care for an individual practice, but finding ways to work across the country wherever patients get their care. That was the challenge. The work in pediatric Crohn's disease actually has its roots in the way in which physicians become certified. So many of us are aware of the fact that we go to what's called board certified physicians. And starting in the early 2000s, the Board of Pediatrics made a decision that they wanted to change the way physician certification took place, not just going beyond just doing a knowledge-based test to actually making sure that physicians could measure the outcomes of their patients their idea was, if you go to the doctor, your doctor ought to be able to say to you, here's the results you can expect based on the last 1,000 patients like you that I've seen. And so that was the aspiration, to be able to put together a system where doctors could actually measure their performance, and then they would actually start to work together to measure performance, to learn from one another, and to advance care through systematic improvement and also through research.
What are the kinds of things when we talk about standardizing? Because these, for the audience, it's like these are not complicated things, but in doing a whole bunch of them, it led to these children feeling better. So tell me about that, and how did you even just take these 9 centers and start to triangulate them?
It's things like charting height and weight. These are kids with intestinal disorders, and it might impact their growth. Are they growing enough? Things like documenting where the site of the inflammation is. Things like making sure if before you take a certain med that you've had a blood test, to make sure that that's okay. And these individual things are all one thing at a time. And the way humans work is they can get it right about 80% of the time for each thing. But 80% times 80% times 80%, it becomes much smaller. And so to get them all done all the time, you can't rely on your memory. You have to have a process, a set of things you do over and over again. And so that's what they start to learn about.
Now, what is the importance of the patient or the parents in that paradigm?
So you asked earlier, what does health mean? What does better health mean? And Kedar said, well, it depends, right? And part of what we came to learn is that healthcare itself is it's not like a toaster. You can't go into a store and buy it, right? It's more like a service. It is a service, right? And it takes 2 people to create that. It takes 2 parties, right? The clinicians and patients and families. And so if we are to improve things, and we only start with the clinicians, we only work on the clinicians, it's like building half the service. You have to have the input from the patients, because they're experts, as well as the physicians. They're experts on their own lives, their own diseases and symptoms.
Now, were you guys surprised, and Kedar, were you surprised the first times that you built one of these networks and then you saw this improvement? Because, it might have worked, it might not have worked, right? Even before this one we're talking about, Michael, you've been working on these ideas, by, in different ways, and Peter in different ways, and you too, Kedar. Were you surprised just the first times you ever saw this work? Because, for me, always thinking that innovation was around drugs, I was surprised at how fast people's lives could improve by, pre-office visits and things that you wouldn't realize otherwise.
When we had the experience to bring people together to actually look and examine how we were doing in an environment where there was enough trust that we could be open to learning from one another, that when we could learn, we could put things into practice and then see an improvement. And when that happens to you as a physician, it's incredibly motivating, and you want to have it happen more. And so, we each had an experience. We've each had experiences where that took place, and it becomes almost infectious. I mean, it generates personal drive, but it also creates drive in groups to keep going.
I want to just jump in from it, because I think what the audience doesn't maybe appreciate or understand is what you all were doing was early it was pioneer work in the sense of this collaboration, where a lot of doctors, would be working in silos. Here you're saying we're going to come together, we're going to share information. It's also around the time the electronic health records were coming up, and the role of technology to help serve what you were doing. Could somebody speak to that, please, a little bit, just to help the audience frame this? Because now it feels normal-ish.
Right. In 2008, nobody had an iPad, right? And people were like, what is this? It's like an iPhone, but giant. What a stupid idea.
Yeah.
In 2012, we were all watching the Olympics on the iPad.
Yeah.
right? So and Twitter was just starting, Facebook was just starting. It was an era of optimism around what the internet could do. But what the internet did do, which is distributed the means of production for information, knowledge, and know-how, culture. And this is Yochai Benkler's work on the wealth of networks. You used to have to have a TV studio in order to broadcast videos. You used to have a TV studio in order to do podcasts. Now everybody has a broadcast studio in their pockets. And we thought, well, if we all are experts and we all have, as Peter said and Kedar said, we've all learned things and we've fixed things and we've made if we all have expertise, how do we best share that? And how can we make it possible for everybody to be part of the solution?
I think it's worth saying, it might be worth saying what the counterfactual was at this time, and the tradition of knowledge production in healthcare is pretty archaic in a way. You do a research study, a randomized controlled study of some kind. It takes 3 to 5 years optimistically to complete it. You generate a new insight about something, and then you publish it somewhere, right? You publish it in a journal, often historically print. Now they're all online, but historically print. Somehow or another, that message is intended to get to every clinician in the country that sees patients that have that condition, and then they're supposed to act on that information in real time, essentially. So, Jesse, you started off by asking a question about the expectation is that all doctors everywhere would do would treat a patient with pediatric inflammatory bowel disease exactly the same way. Well, think about that means of production that I just shared, where you publish something in some journal that somebody is supposed to read, the pace of which, by the way, exceeds the possible pace of human consumption by orders of magnitude every day. Your doctors would do nothing but read journals if they were to try to stay on top of the latest information and knowledge. That was the means of production. And you can imagine how challenging that would be to try to create a system that would reliably produce exactly the same kind of care in every single clinical encounter. And what Michael and Peter and others were doing here with the creation of these networks was harnessing what seems sort of commonplace now, which is harnessing our collective ability to understand what with the scope of human knowledge around a particular condition or situation, each of us individually solving our parts and then contributing to a whole, and critically solving for, and I think this is an undervalued contribution here, but is enormously important, is critically solving for tapping into the knowledge that patients bring into the equation. Is we, until this point in time, from the production of knowledge that I just described, patients were essentially systematically excluded from knowledge production. And in this revised way of thinking of how to produce, co-produce outcomes, as Michael was describing, by definition, you engage the patient and family members and their expertise around A, what the heck they wanted from their health system, and B, what their lived realities was of the condition that they were facing. And that became kind of common practice as a part of these networks, which is fundamentally different than knowledge production prior to that moment.
The real focus is what matters to each individual. That's when we go to the doctor as individuals, that's what we think about. When we work as a network, we need to get a collection of people together to have a discussion about the kinds of outcomes that are most important to people in general. And so that's the starting point, a deep appreciation of really what matters in a profound way to patients. It's not just that not that I got the right treatment, but that I'm able to live my life in the way we're focusing on outcomes that enable people to live the life that they want to live.
Every day in the news, we hear about health disparities, and that can be in a simple way. You could say, well, there's people live on that side of the river, people live on this side of the river, and they're all practicing differently. How do we scale the idea of these networks, which is so vital to do?
I think we are facing a kind of watershed moment, I think, in our collective history, not just in healthcare or in health, but I think, our wider social history as a nation and perhaps world, around whether or not we need more equitable treatment of previously marginalized and vulnerable individuals. In the health environment, I think what we're finally realizing or understanding is that these inequities that we're experiencing, which have been widely documented for decades and decades, are not necessarily inevitabilities, but in fact, a lot like the defects we see around the systems that we've been talking about to date, they're the product of unintended variation in systems, right? They're systems that are and intended or unintended. In some cases, they might have been intentional variation that has led to the disparities that we're experiencing. But in most cases,
that's a terrible thought, and
it is. But I think we are seeing that there are opportunities, just like there are for any kind of systems variation. There is opportunity for us to create a different way forward. We can apply the same methods that we've been talking about here to try to eliminate variation in systems and the way the systems perform, to actually eliminate these kinds of variable performance in how our systems take care of patients. And we can do that network by network, system by system across the country. And we're starting to see some of that, and I think we can extend that much further going forward.
One of the things of these networks is that those first 9 doctors who select in, right, are a certain kind of person. And those kinds of doctors exist on both sides of the river, right? But the question is, how do we find those people? Because it's a self-selecting network of people devoted to a set of underlying ideas. But how do you identify them and then invite them in?
I think when we started, we were doing something very new by bringing patients and families into the whole design process and thinking about co-production and collaboration at scale and creating systems that facilitated that. And now we can see that now it's a matter of helping others to see that, oh, there are other ways of doing this, right? Telling that story more broadly. So it becomes less unusual. You don't have to know a guy, to find it. Susanna Fox talks about crazy obvious, right? Everything, you start something new, it's like, why would you do that? That's crazy. And until everybody realizes, oh yeah, that's obvious. And so that's part of the process now.
There's great differences in the way that you would treat certain conditions. Like how different is the variation in the human condition that makes something more applicable for this or not applicable? Kedar, how do you think about it?
We've run learning collaboratives, which are the progenitor for these learning networks, for hundreds of clinical conditions. I mean, not just IHI, but other organizations that have worked on quality and systems improvement work, including multiple hospitals and health systems and associations. There is no, to my knowledge, there is no condition specificity of these networks. There is no reason to systematically exclude a particular condition, no characteristics of a particular condition. They're broadly applicable to any kind of clinical circumstance or condition that might be present, in which variation is present, frankly. That's the condition. Is there an outcome that is sought and desired that is not being presently achieved by the system as is? And is there variation in the performance present within the present authors of the activity? And if those two conditions are met, and there are some clear ways or better or best practices that are available, then you've got the formula, if you will, for a network. You shouldn't be allowed to practice as a pediatric inflammatory bowel disease doc in the country unless you are part of this network. It is now what it takes to get people to 80 to 80+% remission. The standard of care is so much better if you're part of Improved Care Now that it makes no sense for us to tolerate a practice environment that is not part of one of these networks. And that should become the standard across, I would say, a wider array of clinical circumstances in the future, including things we're working on right now, like pancreatic cancer and end-stage renal disease and a variety of other clinical conditions.
Sorry, I didn't mean to interrupt you, but that's an amazing, I mean, now you're talking about this collaboration, which is, do we need or do we have a culture change, or are we getting there? Where are we in that, where everyone says, you know what, you want to practice this, that you've got to be part of this? And a second part of that question is also, does this network really get us closer to precision practicing, where you can pick and choose and learn, but then you find your patient, you're listening to all those little pieces, the anecdotes that you're getting from them and their parents or whatever, and we can really go in there and really be of service, which is, I think, what you're all talking about, to really serve the Hippocratic Oath, like we're going to serve our patients.
I don't think we're there yet. We're making progress, and we want to see this unleashed a bit more because of the potential that we think it has in all conditions. And I think one of the things that Kedar said that really resonates is that we have, for many, it's easy to treat the systems that we work in with a certain amount of inevitability about them. It's just the way things are. There's a small percentage of people who really are frustrated by the way things are, and they don't want to, they're willing to do something about it. That's where this starts. And to the extent that we can, what the networks do is they allow a large group of people to stop treating current reality as inevitable and to go to work on it. And to have the power of now thousands of people working on the same problem, each contributing what they can contribute, that allows the many problems that arise for anybody living with a particular condition to start to be confronted, to have the diversity of information that we need, and also to really speed up the cycle. So the gap that Kedar was talking about between the old way of doing it, in which we publish a paper and then hope that it gets picked up, and there's a community working collectively on it, then when the results emerge, people start to do something about it.
We've just come through, or we're in the middle of, perhaps one of the most unbelievable forms of clinical collaboration that we've ever seen, with coronavirus. We've got, I remember talking to an emergency room doc early in the pandemic, March of last year, a year ago. And he and his colleagues had put together a wiki for other emergency room docs around the planet that were trying to figure out how on earth to save their patients from coronavirus. And within 3 weeks, that one-page wiki had become 400 pages of information. And there's countless stories of this. Facebook groups that started with a dozen that became 1 million clinicians, all desperately trying to figure out how on earth to keep their patients alive. We have watched probably one of the most amazing forms of clinical collaboration that we've ever witnessed. And you have to wonder, as a heart failure doc is watching this fantastic amount of knowledge transfer and collaboration, why clinical governance for heart failure would not try to replicate that in the future. Why wouldn't we have heart failure registries, which we do have? Why wouldn't we have a clinical practice community that modifies its dominant protocol in real time as new information becomes available always, as a permanent feature of how we treat heart failure going forward? Why wouldn't, as we see more mergers and acquisitions take place, which we'll see many more of in the future, my prediction in healthcare, as these systems get bigger and bigger, the need to reduce variation within system becomes higher and higher, right? So the need for these networks or network form of knowledge sharing becomes increasingly important as we become more and more consolidated and we have bigger and bigger and more massive systems. So this is a solution, not only condition by condition, but as systems get bigger and bigger and they try to reduce clinical variation across the places in which they distribute their orthopedic care or their cancer care or their heart failure care, they also need a solution to how to reduce that variation that's present in their system. Because it's not really tolerable for a patient at Northwell's flagship hospital to receive a standard of care that's better than one of the peripheral hospitals in the Northwell system.
Technology, as Priscilla asked earlier, it's really making possible the collection of all these variations. Does that make the opportunity of now more significant than it's ever been for helping people?
At some level, it makes the opportunity to be able to scale this vast. At another level, the technology that we're talking about is not the most futuristic technology. It's capabilities that we have right now that, if deployed effectively, could accelerate what's taking place. And as we get further and further along to artificial intelligence and prediction recommender engines, all of that can be attractive, but we have enough technology now to be able to help doctors measure what they're doing, to provide the kind of feedback that they need to create places where people can share. The technology has to be connected to a community that's going to use it in a way to drive their action.
Yeah, the technology is it's hard, but the people are the hard part. What we and others have shown is that there's a recipe in a sense, right, for how to do this. because what we're doing essentially is we're creating systems in which people can do what they want to do. People came to healthcare, as Peter started by saying, right, they want to make people better, and patients and clinicians, patients and parents want to get better. They're often stuck in a current system that doesn't allow that. And so by changing the system, there are a set of things that we do that facilitates this kind of collaboration. And then if you add the AI to that, it makes it even more powerful. But what we're starting with is a reorganization of how people work together.
For a physician to participate in this, it does not create more work for them, because we can't ask them to do more work. So Peter, what does it mean for a physician who's thinking about being in a network like this?
It would not be fair to say that you don't have to speed up the treadmill before you slow it down. There is some work up front to make this work. I think the benefit, what we find is that there's enough benefit, there's more than enough benefit by being part of a network to actually make care better. It makes it easy when we start to do things, when we start to change the system in which we work, it makes caring for patients simpler and easier and more focused on what people want. And the work of making the change becomes part of the work that we do. So in many ways, what's taking place is lots and lots of people working together in small ways in a relentless fashion, day after day after day, that produces these large changes over relatively short periods of time.
A patient who watches this or listens to it, why would the loved one or the patient themselves try and build a network or reach out to study, get more information about networks? What does it offer them?
A lot of them don't really know any different. So they're just like, this is how healthcare works, right? And then they might have an experience outside of healthcare, of improved care now, and they think, wait a second, that was not as good. So just the experience, the outcomes, the ability also to be part of something bigger. There are a subset of kids who, not only want to get better, but they want to help their peers get better. Right? They're in their own little tribe. They didn't ask to be put there, but they are. And so this allows those folks to become leaders in that community as well.
Kedar, the payers, do they look at this and better outcomes? What does that mean for the payers system? Do they like this kind of innovation?
You would think so. I mean, I think that is the short answer to this. I think that it would make, for the payers, it means more margin for them, right? You keep people out of the hospital, you keep people healthier. For the premium dollar that they earn, they actually expend less of that premium dollar in theory. It's not always 100% that you expend less. I mean, sometimes you're taking more complex biologics more reliably, and actually you're spending a little bit more, but you're getting better outcome, which is something that the payers also want to have happen. So I think it would make a lot of logical sense, and there's plenty of waste in the variation in healthcare that it ought to make some sense to the payers to do or invest in these kinds of initiatives. I would think that today, if you are a young person with pediatric inflammatory bowel disease, or if you have epilepsy, or if you require a renal transplant, or if you're the parent of someone with left hypoplastic heart syndrome, or if you're a patient with pancreatic cancer, you ought to ask your provider if they are part of a learning health network. Because if they are not, there is a significant likelihood that you are not getting the best possible care in our systems today. I'm not saying it's 100% sure. You may very well be at a fantastic treatment center, but the likelihood increases very substantially if you are in the care of a practitioner who is part of a learning health network, because they are standardizing their clinical practice to the best available evidence, and they are part of a clinical practice community that's rapidly transacting in the latest knowledge. And you're part of a clinical community, a patient community that's trading wisdom about how to live with the condition, which ultimately leads to better outcomes. Not just Jesse, you said earlier at the very top of this conversation, then I thought it was all the meds and the diagnostics and the new therapeutics. Yeah, that's part of it, to be sure. But just as important, as Michael said, is whether or not you're able to get those meds and diagnostics and therapeutics into the body. And so much of that has to do with the way you live your life. And the way you get that advice is not from the doctor necessarily. How could it possibly be that a 55-year-old person, clinician, knows what the experience of a teenager going to the prom would be like with a colostomy bag? That is just not, that's not easy to understand and reconcile. And that's something that you can get from being part of a learning health network. Wisdom of other people who are going through the same circumstance in your life, how to live with the condition. And that, that's worth its weight in gold. It's worth its weight. It's at least on par with, if not more valuable than all of the medications that we can conjure.
Why do we as human beings, the group of us on this call right now, and all the people that we work with, care so much about this, about trying to get better care for everybody, Peter?
This is who we are as humans. We care about each other, and given the opportunity to do that, we want to do it. It's part of who we are as humans, and I think in many ways the systems in which we work sometimes put friction in our ability to actually express that fundamental motivation that we all have.
Well, thank you, gentlemen, for spending time with us today. Incredibly important conversation, and just appreciative that I could hear it.
Thank you.
Thank you. And also,
Thanks for having us.
3 words came to mind as you were all talking at the end there: community, compassion, care. It just all, when Michael was speaking, and then when Peter, you said we're all humans, in the end, that's it. So I'm hopeful that the work that you're all doing, maybe, there might be some scaling possible here, because it's incredibly important. So thank you for everything you're doing.
Yeah. Bye, you guys. Thank you.
Pleasure.
Thank you very much.